The issue, maybe I didn't, somewhere actually feel related to the actually, should you give the vaccine to somebody who's allergic to eggs itself? That's always a question, because is egg allergy a contraindication to giving vaccines especially? And there was some link initially about measles vaccines and eggs, because the measles vaccine itself is developed within the chick embryos, and therefore there's some egg protein in it itself. And they thought that, worried about if you give the vaccine, it may induce some reaction in those who are allergic to eggs. And this was turned to be false itself. It's not a contraindication, except if you eat eggs and you develop anaphylaxis with it. If you develop anaphylaxis with it, then actually you may avoid giving the MMR, for example. But if otherwise, there's no contraindication of giving measles vaccines or MMR to persons who are allergic to eggs itself. If somebody asks you. Varicella vaccine is almost similar, parallel to the same, what we just mentioned about MMR. Generally safe. You have to give it in 2 doses itself. And the concerns about, sometimes you may get in some cases fever and a rash, and that's a side effect, like as if you get a very mini varicella infection itself. The concern was always, could you get zoster? Like with varicella infection, you can get chickenpox, and then later on in life you get zoster infection. Can this happen in the vaccine itself? It may happen, but it doesn't seem to be as frequent as one would expect it, a natural illness itself. So that is probably a non-issue in itself. And probably this might be the last vaccine. Hepatitis A. Hepatitis A is probably familiar with the disease itself. It's a fecal oral one. You get jaundice with it. Now, jaundice, this tends to occur more in children above 8 years of age. Below 8, you can get hepatitis A without actually having even jaundice with it. Asymptomatic or anecteric hepatitis A itself. Now, there was a question about people, a lot of pediatricians say, well, hepatitis A is actually a mild illness in children, and even when they get jaundice, only very, very rarely, maybe 1 or 2% may get hepatic failure with it. And so do we need a vaccine for it? And that is probably true in a sense that actually of all these vaccines, this is what I call sometimes a luxury vaccine. Actually, this is if you have enough money, you can give it itself. But is it a top of the list type of vaccine, like, for example, measles vaccine or Haemophilus influenza or whatever, because these cause meningitis? So this is a sign of question in it. But actually, people, especially those who had, if you had a child who had jaundice, would be caught. Actually, jaundice itself, although it may not be harmful to that child, but actually causes more panic in the family itself. And so, for that reason, actually, a lot of people request this vaccine specifically. Nowadays, actually, there is a vaccine, but I don't know if it's available. I don't think it's available yet here in this Saudi market. But actually, a combination of hepatitis A and B together in one vaccine itself. meningococcal probably got delayed. meningococcal اللي هو third encapsulated organism اللي هو زي Haemophilus meningococcal. This meningococcal is same in terms of actually to the vaccine which is given في الحج اللي هو meningococcal vaccine. Now it's different from actually that vaccine. This is a new meningococcal vaccine, and it's one of the what we call conjugate vaccines. لو في يوم نتكلم عن conjugate, which is actually different from the regular vaccines itself. Conjugate vaccines in general are vaccines which because these are encapsulated organisms, when used to be given in children under 2 years of age, had problems in producing enough antibodies. They invented a way of stimulating the immune system by conjugating the polysaccharide part of the organism with a protein. And that seems to stimulate the immune system to produce enough antibodies to protect children under 2 years of age. فهتلاقي في regular vaccines above 2 years of age, which is effective in adults but not effective in children. But under 2, you use only the conjugate vaccines because. And so this is a conjugate vaccine, meningococcal vaccine. Against the same serotypes اللي هو في زي بتاعت الحج الفاكسين زمان اللي كانوا يعطوه الحج اللي هو AC W135 وال Y. B we never had a vaccine against B للأسف. Therefore actually it is the same serotypes itself, but as I said this is a conjugate vaccine, and so it can be used under 2 years of age, and also it's effective. It's given at the age of 9 months and then I think at 1 year of age. Again, quite safe vaccine itself. So these are actually the overview of all the compulsory. I didn't go into the optional vaccines, but at least these are compulsory vaccines that you're going to be, which are mandatory by the schedule. As I said, we don't expect you maybe to remember all the vaccines in terms of the scheduling, but you should probably be familiar with some of the indications and some of the side effects of these vaccines. And I think there's enough information in the slides which may help you in that respect itself. And as I said, it's important because it's an issue always that you're going to be asked by mothers when you see them in the clinic, or from family members who actually are planning to have their children vaccinated and all that. Okay, we'll stop shortly, answer a few questions, and then إن شاء الله بعد كده نديكم 2-3 minutes وبعدين نبدأ ال TB. Okay. Okay. TB is actually, we think more of it of a special, I usually give it after respiratory because it can be a special type of respiratory infection, although TB in itself can actually produce, as we're going to see, not only respiratory infections, but actually it comes in differential diagnosis of even systemic infections in general in itself. And that makes it important. That because it can actually take different pictures, it can involve different systems, and the added importance of it for us is actually there's a lot of TB around in the Western region itself. So it's one of those things that you should keep in your mind. And we're going to think it about in terms of differential. I'm not going to go in, actually, I'm going to talk about gender. I don't think you've taken in 4th year or in medicine because TB in adults, I think. في الفورث يير مع لو كانوا يعطوا المحاضرة دائما يكون عندنا بعد المدرسين يعطوها لكن which makes it easier. So actually because I'm going to really what I'm going to do here is I'm going to focus on the pediatric aspects of TB itself. It's a very big topic itself, and I don't expect to go into details about especially the clinical part. You might be familiar with the general clinical ones, and so I'm just going to show how highlight some of the differences between pediatric and adult TB itself in terms of the clinical, and just focus on those things itself, and then maybe discuss TB later when you have cases of TB that might be more important or more appropriate. Now, TB, these are the organisms. Now, in children, we tend to see more of the Mycobacterium tuberculosis. That's the usual human ones itself. In adults, because TB occurs there not only in normal children or normal people, but actually in immunocompromised. So we tend to see the other strains of Mycobacterium, avium intracellular, for example, in HIV patient itself. So it produces almost a similar picture, but with a different strain itself. But most TBs in children is due to the Mycobacterium tuberculosis itself. The bovis actually, which is what we mentioned about the vaccine, in children used to use it in the past, how 30 years ago, when there was a lot of when the people drank cow's milk, unpasteurized milk, they used to get Mycobacterium infection, and it occurs usually mostly intestinal type of TB itself. But nowadays, actually, with pasteurization and all that, this doesn't happen at all. Yeah, it is an acid fast one. I mean, just tell you that actually by gram staining it should be a gram positive one, but actually gram stains very poorly. We use other stains like a Ziehl-Neelsen stain itself, and it stains red with it actually. If it was a gram positive, it would have stained blue itself. So it's red. So what we see usually is the red rods. It's a rod shaped. مش عارف الاستناد دي. مش عارف if it's working. But anyway, you might see the beside some red rose itself, and because it doesn't actually look very clear, that's why most labs now use what we call ornament sulfate one, which actually you see it a yellow rod against a fluorescent background, a fluorescent green background itself. So this is more popular now because actually it's easier to see with your eyes, differentiate between the yellow and the green than between the blue and the red itself. And this is just the electron microscopy picture, just to prove that it's a bacillus, it's a rod. Now, epidemiology, in a sense, what does that mean from a clinical point of view? This is actually the kind of situations. Now, you're going to see somebody, let's say, with pulmonary TB, and you say, well, how would that differ from somebody else with another bacterial infection? How do I know that this is TB itself? We might touch upon a few clinical pointers later on, but at least a very important part is actually the circumstances in which occurred and the history itself, in a sense. So actually, usually TB will occur in places where this tends to occur in places with low socioeconomic people, overcrowding, people living especially from poor slum areas, and they're all a lot of members of the family living in one room, for example, 5, 6, 7, 8, whatever. That kind of thing is always, we find it. Those who tend to have, now the immune system itself, which part of the immune systems we said deals with TB? The T cell itself. So those diseases which are associated with T cell dysfunction, like leukemias, for example, or if we use drugs like steroids or anti-cancer therapy, they suppress your T cell and so make you more prone for TB itself. So if you have patients like those and you get a pneumonia, so you should put TB as one of your differential diagnoses. So that's in a sense what's the whole idea. I mean, if you consult and they say, well, this is a child and who's got pneumonia and it's not improving. Now, you might change the antibiotics and all that, but if you find out that actually this child is living in comes from a poor family or from slum areas, I mean, and or actually he's got cancer, maybe he's on cancer chemotherapy and all that, steroids, then you say, oh, this increases the possibility of TB, therefore I should consider TB as one, not just the common bacteria ones. So that's the importance of knowing this information, the epidemiology of this disease itself. It helps you in making your diagnosis itself. Transmission itself, transmission is by inhalation, the particles, and these usually two things about the transmission. One, the source is usually an adult and not a child. And the reason being actually because adults produce more bacilli than children. Children, as we're going to see, primary TB, the amount of bacilli produced are low. While in adult type of TB, the regular one, the classical type of TB, the cavitary type of TB, cavitation, there's a lot of caseous material and a lot of bacilli itself. So in terms of actually amount of that coughing, and also the important thing to remember about the airborne, because now there's a difference between actually diseases which are transmitted in the air. Some of them we call them airborne, and some of them we call them droplet infection itself. And the difference is basically actually in the distance that actually the bacteria can travel. If it travels a small period, like, we call it a droplet infection itself, like in meningitis or most influenzas, for example. While those who can be suspended in the air for a long period of time or go to very long distances, we call them airborne infections itself. And they're more dangerous, of course. And the important ones are, well, these are like TB, measles, as we mentioned, as we talked about, we mentioned measles at least, and chickenpox. Chickenpox also can go from one room to another, actually, without direct contact. While usually most those with droplet infections like meningitis, you have to be close enough to the. So these important features is to remember about behavior about TB itself. So when you have it, first it helps you in terms of deciding about isolation. So this, when we talk, we may talk about isolation later. But at least in terms of transmission, if you have a case of TB, then you shouldn't go around, looking for a child. If you have a child in the school who comes down with TB, probably better to look for an adult, maybe a teacher or maybe one of the workers who's working, the maid or something like that, rather than looking for another child. Children then not to infect, generally speaking, طبعا في exceptions, لكن not to infect other children itself. Usually an adult infects a child, an adult infects an adult too. And I mentioned that already, and probably. Incubation period in 2 to 8 weeks, this is to remember, and so it takes some time. So it means that actually, what does it mean actually? If it takes about 2 to 8 weeks to know that somebody has been exposed to the bacillus, if you go through a room and some of the bacilli got in your system, how do I know that actually you've been exposed? It might take 2 to 8 weeks to know. The answer is that before you develop a disease, or at least you develop some kind of test that you can detect whether the bacillus. And the test we have here is the PPD skin test, actually. This is the way we do it. And so if you develop the disease, that's it. But if you can develop a reaction in the skin, because it's a delayed hypersensitivity type of infection, you develop a positive skin test, and that will tell you you've been exposed. But because it's 2 to 8 weeks, so you shouldn't do the PPT skin test immediately after you get exposed. You have to wait at least 2 weeks, or most likely you actually to wait 2 months, the 8 weeks for the. And so whenever you, for example, if you come and tell me, actually I want to see a patient, I discover that he's got TB. How do I know that I've been exposed really? And afterwards I know that it's TB. So can I do a PPD skin test? Yes, but not now. Actually, we do one now, for example. This is to know actually whether, if it's positive, then it's probably from a previous infection and not this infection. So we do a baseline, and to know if it's negative, then we wait for another maybe 2 months, and then repeat the test itself. If it becomes positive, what we call skin conversion, then it means that you've converted, your skin converted from negative to positive, then you've been exposed to that. To that person himself, and he got TB. Or after 2 months or 3 months, you do the test and it's negative, then we'll tell you, no, it's unlikely that you've been exposed. So this is the importance of knowing the incubation period itself. Now, the bacillus actually, this is show that actually when it comes inside the system itself, it's not only pulmonary. Actually, pulmonary is just the gateway. You get pulmonary disease itself, but actually, the first time actually you may get inside the lungs, and it goes to the lymphatics, to the local lymph nodes, which are the higher lymph nodes, and stays there. Some of them stay, and some actually keep traveling to go to the blood and go to the other parts of the bodies, all the other organs. And some will stay there for years, actually. And that's why you may get exposed as a child to bacillus, but later on you get urinary TB. Urinary TB, when you get it in the 20s or 30s or 40s, is actually due to the bacillus that you acquired as a child, and not usually to a new one, actually. It's just hidden there itself. And that's why actually, so in children, actually, most infections, we tend to see more extrapulmonary TB. Most adults will get it goes to the lung and stops there. But in children, actually, it goes beyond, and we see actually more extrapulmonary TB. We see miliary TB. Miliary TB is, in a sense, like sepsis when you say bacteremia in bacteria, for example. So bacillemia or miliary TB is a multi-organ disease itself, illness, and so. We see extrapulmonary and miliary TB tend to be more common in children than in adults in general. Now, when you get exposed to the bacillus itself, it gets inside your body itself. You either it may hide there, or you may develop symptoms itself. If you can prove, if you get PBD positive, then you've got the infection itself. I mean, if it gets inside the body, then you got infection. The question remains always, is it just an infection or disease? Now, people use the same term interchangeably, but actually they mean different. Infection means an organism gain access to your body, went inside your body, and stayed there, and you have that disease. But you may not manifest itself. You may be even asymptomatic itself. But if you manifest the disease, the manifestation of the infection itself, then you have disease itself. So disease, like HIV, for example, HIV, you can get the virus inside the body and you can test it and you turn positive, but the child is healthy otherwise. Then we say he's got HIV infection. But if he develops manifestations, pneumonia, whatever, because of that, then we say he developed HIV disease. And HIV disease is AIDS. Actually, AIDS is the disease part. It's not infection. I mean, the whole thing is called HIV infection itself, and disease is just the symptomatic part itself. So this is the same thing with TB. We have asymptomatic one, and we sometimes we call it latent TB or active TB itself, in which you have the manifestation itself. So this is important because the management is different itself. We talked so latent TB or infection is actually no symptoms, only a positive PBD skin test. Having a positive X-ray is considered a symptom, or at least push you into disease and not away from the infection itself. Now, ندخل في pulmonary disease. Pulmonary, now we focus on two major parts of the clinical manifestations in TB. As I said, we're going to give an overview. I'm not going into details. But the most important presentations we see in children is actually pulmonary disease and adenopathy. These are the comments that we tend to see in the clinic, or even in the adenopathy in the clinic, and pulmonary disease either in clinic or in the ward itself. Now, the classical. Now, what happens actually? TB lungs, because it happens to the port of entry of the organisms is the same for the end target of the infection itself. The end target is usually the lungs itself, but at the same time, this is the way you enter, the bacteria enters the system itself through the lungs. So actually, whenever we ask about what's the clinical manifestation of TB, and people start saying about coughing, hemoptysis, and productive cough, and night sweats, and so forth, and all that, that tends to be what we call the other type of TB itself. Now, children actually, whenever you get the bacillus, it gets inside your lung itself. As I said, some of the times it just travels from the alveoli to the lymphatics to the lymph nodes and just stays there. A lot of times you don't have any symptoms at all. Sometimes you may have at the alveolar level a pneumonia. So pneumonia might be just simple, and it can be no different from any other type of pneumonias. Occasionally, this pneumonia might spread around and produce severe pneumonia, and we call that, all of that we'll call it primary TB. So, but it spreads, and we call it progressive primary lung disease itself, or primary pulmonary pneumonia. So actually, but mostly you get the pneumonia itself. So sometimes, as I said, you miss the pneumonia and you have lymphatics, and you go to the local lymph nodes and you produce hilar lymphadenopathy, and that could be the only presentation of the pneumonia itself. So that is so the different presentation could be asymptomatic with no symptoms at all. Could be just simple pneumonia, simple lymph node enlargement itself, progressive pneumonia itself. Sometimes it breaks into the pleural cavity and you can get pleural effusion. So these are different forms of the ones. And usually, most of the time, the immune system overcomes it, and you get actually resolution of the symptoms. And then later on, either due to exposure once again, if you're in the same community, or reactivation of this old focus itself, because as I said, it goes and hides inside the body for years. And then for whatever reason the immune system weakens, then you get reflourishing or redissemination of the organism itself. Now the second time, actually what happens is now that the body is actually ready for that, actually develops its own antibodies against it. So it starts to try to fight this organism itself. Now this fighting, the first time it didn't fight, but the second time when it goes inside the lung and they start fighting, then you have a battle inside your lungs itself. It's a fight, and then it's an antigen-antibody reaction itself.